Dear chairs, dear audience, my name is Patrik Kreuter, and I would like to present my PhD topic, the latest advancements in digital orthodontics. I'm a first-year resident at the Department of Pediatric Dentistry and Orthodontics. My supervisors are Noemi Rózsa and Dorottya Bányai. My SMS is Petrana Martinekova, and my statisticians are Gergely Agócs and Alice Fazekas. My vision is to help more people smile confidently, and my mission is to contribute to the development of orthodontic guidelines, providing high-quality treatments without compromise. I have two ongoing projects, which are both systematic reviews and meta-analysis. The first one is titled Investigating the Differences in Root Resorption between Fixed Appliances and Aligners in Permanent Dentition. The traditional fixed orthodontic appliances often cause aesthetic and hygienic difficulties during the treatment. However, aligner treatment, also known as invisible orthodontics, is a more comfortable and aesthetic way to treat orthodontic patients. Orthodontic treatments often cause root resorption, also known as orthodontically induced inflammatory root resorption, and it can occur into only 20 to 100% of the cases. Aligners previously showed a lower incidence and severity of root resorption on radiographs. However, more accurate three-dimensional CBCT studies have been only conducted recently. Our aim is to investigate the differences between aligners and fixed appliances in orthodontically induced inflammatory root resorption. Our clinical question is how do aligners perform in terms of root resorption compared to fixed appliances, and we use the PICO framework where the population is patients with permanent dentition. The intervention is aligners compared to fixed appliances, either conventional or self-ligating fixed appliances. Our primary outcome is root resorption measured as root length change on CBCT records, while the secondary outcome is the same measurement on radiographs. Our hypothesis is that aligner therapy causes less severe root resorption compared to fixed appliances. We've conducted our systematic search on the 13th of November last year in 4 databases, and after the selection process, we have 6 eligible full texts, out of which 5 is eligible for meta-analysis. We have 2 outcomes, the root length change of upper central and upper lateral incisors on CBCT recordings. We have finished both analyses, however, we will have some minor adjustments in the following weeks to make it perfect. So on the first forest plot, the outcome is the root resorption of upper central incisors, which means a linear root length decrease of the teeth. We can see that the outcome is in means, so it's a millimeter difference, and it's negative as all teeth decrease in length during the orthodontic treatment. The population of 5 retrospective cohort studies has almost 300 patients, and we can see that the I-square ranges from 11% to 87%, so we can see high heterogeneity, which can be because of the different types of malocclusions. As we can see on the right column, the angle classification was different between the studies, so the tooth movements necessary during the treatment were different, and also there are some demographic differences as well. We can see that the highest number of root resorption was present in the fixed appliance group, the conventional fixed appliance group. However, this minus 0.96 millimeter doesn't reach the clinically significant 1 millimeter threshold, and also we can see any statistically significant difference between the 3 groups. The second forest plot has the same outcome, so a mean difference of root length. Here we have 4 included studies with 187 patients, and we have also the aligner, conventional and self-ligating fixed appliance groups. Here we have similarly high heterogeneity, which can be explained the same way, and we can see that there is no statistically significant difference between aligners and fixed appliances at this teeth type either. The strength of our studies is that is the first quantitative analysis based purely on CBCT studies, and only 2-arm studies were included, and most articles were published within the last 3 years. The limitations are that only retrospective studies were available in this topic. There is a high heterogeneity, and most available studies present at least a moderate risk of bias. Our conclusion is that aligners and fixed appliances cause a similar amount of root resorption. The implication for practice would be that both interventions can be used for the patients who don't present the known risk factors of root resorption. Self-ligating appliances and aligners may cause less severe root resorption, so the use of these appliances should be negotiated during the treatment if we treat patients with risk factors. And also the upper lateral incisors seem to be more prone to root resorption, external apical root resorption, which was well known in the literature. The implication for research is that there's a need of high quality RCTs in this topic, as there aren't any available. Further studies should investigate the differences between the fixed appliances, the conventional and self-ligating ones, and also, as one study presented a 3D volumetric measurement of root resorption, it may be the most superior way to measure root resorption. Here you can see the progress of my first project. As I've mentioned, we are during the manuscript writing status, and right now we are revising the plots, and I will have to redo the discussion and results part to finish it. My journal of selection would be the Journal of Dental Research. My second project is titled Analyzing the Failure Rate and Adverse Effects with Indirectly versus Directly Bonded Orthodontic Brackets. So the conventional direct bonding of multi-bond appliances requires high precision, as the operator has to place each bracket manually. If we misplace these brackets, we can cause unwanted tooth movements, which delays the end of the treatment and changes the outcome. Indirect bonding offers a more predictable and precise way to place the brackets, and also it decreases the chair time. Several articles show controversy regarding differences between the two modalities in terms of bond failure, plaque accumulation, or formation of white spot lesions. And since the latest reviews emphasize the weakness of available evidence, new articles, including RCTs, have been conducted. Our aim is to objectively compare these two methods in the aforementioned outcomes. The clinical question is, what's the performance of indirectly versus directly bonded brackets in terms of failure and adverse effects? Here we use the PICO framework as well, where the population is multi-bond appliances, the intervention is indirect bonding compared to direct bonding. The primary outcome would be debonding, and the secondary outcomes are plaque accumulation and formation of white spot lesions. Our hypothesis is that the indirect bonding is non-inferior compared to direct bonding in these outcomes. The clinical implication would be less chair time at the orthodontist with similar occurrence of adverse effects. We've conducted our preliminary research in 3 databases, and we are currently working on the Prospero registration. To sum up my projects, I have 2 ongoing meta-analyses in the topic of the latest advancements in digital orthodontics, and I would like to thank you for your attention with a quote from Spinoza: "The highest activity a human being can attain is learning for understanding, because to understand is to be free." Thank you for your attention.
I have 2 questions right now. The first one is regarding your first project. We can see the threshold for the root resorption is 1 millimeter, and it's a consensus, as I understand it.
Sadly, there's no consensus regarding the clinically significant amount of root resorption. So the previous most comprehensive D1 publication, which was a similar meta-analysis, stated that it's a 1 millimeter cutoff value, but to be the strictest, we used 1 millimeter as a benchmark. Other publishers used either 2 or 3 millimeters as a cutoff value.
And what do you think, why this is the value that's also the one? Maybe if the root resorption is higher, the survival rate going to be lower, on the vitality is in risk of the tooth, or what is the reason?
Sure, so there's data available on the longevity of the teeth related to root resorption, and we can state that the higher the root resorption, if it exceeds 3 or 4 millimeters, it equals to a 1 millimeter loss of bone surrounding the teeth. So yes, it affects the longevity, and the reason why we use the lowest cutoff value is to emphasize that there is no difference, even though that all these Mostly company-supported articles suggest that some aligner companies, which I wouldn't like to name, are very superior than fixed orthodontics.
Okay, thanks. And my second question is regarding the second project. So according to the direct and the indirect bonding techniques, how the experience of the orthodontist can influence these factors that you are investigating, and also my question is about the amount of cement they used. So it could be different in the direct bonding and indirect bonding?
Sure. So the history of the operator, of course, changes a lot. So the experience matters a lot. Most of the studies try to at least show us that how much experience do the operators have. And it's going to be a big confounding factor, of course. And yes, matter of fact, several bonding materials are available both for direct and indirect bonding, and they do differ a lot as well. If I'm correct, Professor Varga had a meta-analysis on this topic, so it's a widely researched area as well.
For your second project, I saw that as outcome measures, you chose debonding and white spot lesions, which could be multifactorial. But as you have pointed out, direct bonding, in case the positions are not correct, may lead to iatrogenic complications as well. So maybe you might want to add that to the outcome measures if they are reported in the literature. The second is maybe a simple question, because in your first project you have observed that self-ligating brackets have a lower tendency to cause root resorption. What may be the reason for that?
Yes, thank you for the question and for the comment as well. So self-ligating appliances have been widely advertised because they offer lighter forces during the orthodontic treatment, and that is because maybe I can show that in the presentation if I go back for a second. So as we all know, the orthodontic wires are placed in the orthodontic brackets, and depending on the system, different ligatures are used to fix the arch wire in the brackets. And the self-ligating systems differ from this conventional one you can see on the picture, because here we use either elastic or metallic ligatures to fix the arch wires, while self-ligating brackets have their own kind of lock system, and that offers less friction. And if there's less friction, we can use lighter forces, so that may be the reason.
In the selection flow chart, you said there are 5 studies for meta-analysis. However, in one plot, I saw 7 studies. Could you elaborate on that, please?
Yes, of course. So the my article was the only one where they had separate groups for 3 types of malocclusions. So the most common classification of malocclusions is created by angle. We have 3 classes, angle 1, 2, 3, with subdivisions. And it can be a big confounding factor, as the movements of the teeth are essentially different between these groups. And as they had a high number of patients and they had these separate groups with separate outcomes, we decided to create 3 separate rows for them and also add the comments of the other articles.